Hi. I just want to thank everyone for coming today. My name is Susan, and I have the privilege of introducing Dr. Katherine Nickels. She's a certified neurologist with special qualifications in child neurology, clinical neurophysiology, and epilepsy, and has been practicing for over 22 years. She is an associate professor of neurology at Mayo Clinic in Rochester, Minnesota. And she has expertise in pediatric epilepsy in a variety of areas with pharmacology, diet, as well as surgical methods. And she's also an expert in analysis of clinical EEG. She has participated in numerous clinical trials with investigational anti-seizure meds, which have been brought to market. She has significantly contributed to research and is extensively published. And her area of expertise, she has extended by collaborating with pediatric epileptologists across the country with PERC, the Pediatric Epilepsy Research Consortium, where she is a leader and has served in identifying best practices and treatment outcomes, particularly for early onset of pediatric epilepsies. Dr. Nickels is the EEG lab director and course coordinator for neurology residents, fellows, and neurophysiology tech program. And she is a recipient of Outstanding Physician and Scientist Educator Award. And in addition to that, she serves on a number of boards and is part of the Professional Advisory Board of the Epilepsy Foundation in Minnesota. And we are lucky to have her speaking today. She is part one of the genetics talks in the series today. Thank you.
All right, thank you very much. And among those other things, I'm also relatively short, so I hope that you can see me. Now, you will notice in that list that I am not a geneticist. But I was given the task of explaining why genetic testing is so important. And I think that is important. So the answer here is genetic testing is so important to the practice of epilepsy that all, especially pediatric epileptologists, spend a lot of time doing genetic testing, genetic counseling. It is integral to our practice, even for those of us who don't have specific training in it. And so Brad asked me to do the introduction part of this Part 3 series of why we need to do genetic testing. And the honest answer is this could be a pretty short talk. Why do we need to do genetic testing? Because that genetic testing plus MRI is what is most likely to give you the answers. But I have 50 minutes to talk, so I'm going to talk a little bit more. I have some disclosures. As Susan was saying, I do a fair amount of consulting. I don't actually get any funding for it. I do intermittently have pictures throughout. They are actually of my own children, who are all adults and used with their permission, mostly, when they realize what I'm doing. So since we have 50 minutes and I'm the introductory part, let's talk about what genetic testing is. You can't understand why you should be doing a test if you don't understand what it is. So how do we do genetic testing? What do we learn from it? What does it benefit you? So again, genetic testing and MRI are the two tests that are most likely, hands down, to give you the answers for why someone has epilepsy or a variety of other neurologic conditions, including autism spectrum disorder. Genetic testing also, if we identify a specific genetic abnormality or change, sometimes that change can be associated not only with epilepsy or neurologic disorders, but also kidney problems, heart problems, skin problems. And not just in that person, but there may be family members who have that genetic change and don't have the brain part of it, but they might have the kidney, heart, skin, etc. So it tells us about what other disorders we should be screening and watching for. If we're able to identify a genetic change, that helps not only give you answers and closure, but also allows you to plug in with other families who have a loved one with that same genetic change. And some of our family support groups have been the go-to group to then educate physicians. You know, I may take care of a handful of children with a whole bunch of disorders. On the other hand, it's very powerful when you have a family and a family group where all they live with is that disorder. The best example is the Dravet Syndrome Foundation. They teach providers how to care for these kids, what to look for. And again, it also gives you answers of likelihood of other family members being affected. Siblings, children of siblings, and remember, not everybody who is affected with that genetic change will necessarily have all the same symptoms. So today we're going to talk about what genetic testing is, why we're going to do it, who should have genetic testing. Not everybody requires extensive genetic testing. And then I actually have some examples. So when we talk about genetic testing, this is a very important point. Just saying that you've had a genetic test does not mean everything. There are so many different forms of genetic testing, and they all work together. It's not necessarily that one is better than the other. They all work together. Plus, the field of genetic testing in epilepsy is expanding exponentially. So just because you had genetic testing 5 years ago or 10 years ago does not mean you've had genetic testing. So when we're doing genetic testing, sometimes we're looking for just a tiny little single nucleotide change. Sometimes we're looking for deletions or duplications. And then all of these changes are compared to, we have references across multiple populations, including specific ethnicities, and they are rated. Everybody has genetic changes. You know, think about identical twins, right? You know, they came from the same genes. They are not 100% identical. And why is that? Because everybody has little genetic changes. It's what makes us unique. Some genetic changes, vast majority of them, are totally asymptomatic, whereas some of them will cause symptoms, some of them will cause trouble. And so when they see these genetic changes, what they'll do is they compare it to the database and they say, yeah, this is a known troublemaker. This is a known, a lot of people have it. And then you also have what comes in between, which is the ever popular VUS, variant of unknown significance. That's the one that drives everybody crazy, right? Where we just don't know. So when we do single gene testing, again, some genetic changes or some syndromes are really, really clear cut. And so when we see a child or an adult who has epilepsy and they have other features that are really classic for that disorder, we might do just single gene testing. The best example is tuberous sclerosis complex. There's a specific constellation of symptoms that we look for. It can even be a clinical diagnosis even without genetic testing. So rather than doing extensive genetic testing, we're just going to go right for the money and do tuberous sclerosis testing. Same thing with glucose transporter deficiency. It has a really clear-cut way it presents, and so we might not do an extensive testing. We might just go right for that single gene sequencing. That's what genetic testing used to be. I've been doing this for a while, but I remember when they started introducing the infantile epilepsy panel. Guess how many genes were on the infantile epilepsy panel? Anybody know? 4. That was a really big deal, guys, okay? And that was only, I want to say like 15, 16 years ago. It was not that long ago. So before that, this is what geneticists did. They came in. How many of you guys have seen a geneticist? So do they still go through and they're measuring palm size and ear size and the distance between the eyes no, not so much. That's what they used to do. They would do all these measurements and then they put it into a database and it would spit out a gene because all you could do was one gene test at a time. It was very expensive, took a long time. Back then you could also do a karyotype, and karyotype is still helpful. That's when we just look at the chromosomes. That's like the most basic genetic testing that you can do. It's going to pick up big changes, but it still has a role today. There are certain epilepsy syndromes that are associated with the chromosome becomes a ring, like ring 20, and that's only going to be picked up with the karyotype. So don't think that the old ones are necessarily the bad ones. This is still helpful, and that won't be because it's not a genetic deletion or change. It's a change in the shape of the whole chromosome. And so we'll need to do that one. The next step is a chromosomal microarray, and that's a nice screening test. It's not specific for epilepsy at all. It picks up the most common genetic changes that you might see in any sort of neurologic disorder. So again, that's a really good screening test. That the chromosomal microarray plus the MRI is where you start off for anyone who has a neurologic disorder. And then we get into the world of next generation sequencing. And this was the big game changer. This is what allowed us to look through so much more information, so much data. It's rapid sequencing. They take large DNA sequences and they kind of chop them up, and then they go through and they evaluate all of it. It takes intense interpretation. It takes a lot of time. We do that often when we don't find the answer with a karyotype or microarray, but the reality is that this is more cost effective to move right on to the next generation sequencing. It's just a little bit harder to get and can be more expensive. So the next generation sequencing, these are the gene panels. Anybody familiar with, anybody been told, yeah, I've had an epilepsy gene panel? Yep, that's pretty standard. That's, again, considered to be one of the more cost-effective things to do. So now instead of testing one gene or testing 4 genes, most of them are looking for about 300 genetic changes. And because we're looking at such extensive data, it's all going to be put through the filter of whatever disorder we're looking for. And so there are gene panels for a variety of things. And that's another take-home point. Just because you've had an epilepsy gene panel does not mean that you have been tested for Ehlers-Danlos. That came up recently. Does not mean that you've been tested for other genetic disorders at all. You have gone through the epilepsy screen. And then last but not least, we have the whole exome and whole genome sequencing. Again, you're still not looking at absolutely everything, but it's good at finding the answer when other testing hasn't. It's also good at finding variants that may or may not contribute to what's going on. So it is important when you are signing up for this world of genetic testing that you know what you're getting into. Because you may find things that you weren't expecting that don't have to do with neurology at all. Because they're looking at so much information, this is typically done as a trio, and so it will be the patient and then their parents, because they show up with so many of those lovely variants of unknown significance that they're going to automatically look and say, okay, do the parents have any symptoms? No. Do the parents have this variant? Yes. Is it likely to be causing symptoms? Probably not, because it was just inherited. The parents have it, so it's fine. And these, unfortunately, can take a while to come back. There are some rapid screening programs, like we have one for our tiny babies, for our neonatal ICU babies, where we can do rapid whole genome sequencing and get the data back in just a couple days. But most places, it will take several months to get back. So what are the downfalls? Why wouldn't you want to do genetic testing? Well, no test is perfect, of course, and here's the most important thing. A normal genetic test does not exclude a genetic cause. The best example, so in my family, you know how there are some families where disorders just kind of run through them. So autism spectrum disorder marches through my family like a parade, okay? High functioning, but half of us have it. I have had whole exome sequencing, and my genetics are squeaky clean. Does that mean that the autism spectrum that is in every single generation on my father's side of the family isn't genetic? I would disagree, right? So, normal genetic testing does not exclude a genetic disorder. Normal genetic testing just means that our testing is not yet sensitive enough to pick it up. So that's why a normal genetic test, just like MRI, a normal MRI means you go back and reassess every few years until we find the answer. Genetic changes in parents may not be picked up. So let's say we find the genetic change in the child. Parents want to know the likelihood of other siblings, if they have more child, what's the likelihood of that other child being affected? So we do testing in the parents, and the parents are negative. Does that mean that there is zero risk of another child being affected? No, it means it's a low risk, but not zero. It's possible that the parents don't have that genetic change in every cell. That's called mosaicism. So we just didn't test the right cells. Or the genetic change might actually be at the sperm and egg level. And we're not going to test those, obviously. And so it's not zero, just means it's a low risk. And then last but not least, we might pick up stuff that we weren't expecting. So again, why is genetic testing so important? Why are we going to do it? It gives family closure. Epilepsy is a hard disease. We find an answer about half the time, which may not sound great, but I challenge you. How often do we find the genetic cause for type 1 diabetes? Cancer. Sometimes. Maybe some breast cancers, Ulcerative colitis, Crohn's disease. We don't. So maybe cut your doctors a little slack. Recognize that us finding a cause 50% of the time is actually pretty good, but we can certainly do better. And when we find that answer, it's so helpful. Again, it provides families closure. It provides them access to support groups. It allows us to do counseling for likelihood of additional affected members. But this is where things are really getting new. It also helps guide treatment now. There are disease-specific treatments that are, and I'm not talking about gene therapies. Gene therapies are in the works, especially for Dravet syndrome. But there are also specific medications that might be really, really good for some gene changes and really, really bad for other gene changes. So identifying that genetic cause does allow you to do something about it. Even if it's not gene therapy, it can help guide us treatments. It also helps us try to use our crystal ball and give us an idea of long-term outcomes. So, yeah, I said that some medications are really good depending on your genetics, some are really bad. Why is that? I'm not talking about gene therapy at all. To understand that, you have to understand how the medications work. Anybody know exactly how their medications are working? See, you got to get your doctor to draw out the synapse for you. And yes, I do this in my clinic because it's really hard to take medications, at least for me, it's hard to take medications if I don't know how they're working. And I want to know exactly how they're working because I'm a neurologist. We like to know these things. And if you're taking more than one medication, more than 2 medications, more than 3 medications, you start to question, what are we doing here, right? Are we just pulling things off of a list? Well, I can promise that's not the case. So here's what we think about. We think about how that information is getting through the neurons. This is called the synapse. And it's a relatively simple concept. So what happens during this normal synaptic transmission is you get calcium coming in, and then when calcium comes in, we have these little vesicles of glutamate that goes across the cleft. It binds here with AMPA and NMDA receptors, and then when that happens, we get sodium coming in, and we get our action potential. So that's what happens when the brain is working normally. When a seizure is happening, this gets into a cycle where it's just going. And it doesn't allow that normal information to happen. We also need to keep things at bay, and so we maintain our membrane potential with chloride, and we reset the whole thing with potassium. So why does that matter? So when I am taking care of patients in the clinic, I'm going to go backwards here, and I'm explaining to them why I have prescribed this medicine, this medicine, this medicine, I'm now going to say, okay, you're on this medicine that works here, you're on this medicine that works here, you're on this medicine that works here. So we are blocking that cycle at multiple places. What that also means, though, is here. So if someone has a genetic change that affects the sodium channel, and it is a loss of function chain, then if you put them on a sodium channel blocker, that's going to make things worse, right? On the other hand, if they have a gain of function change at the sodium channel or at the potassium channel, then putting them on a sodium channel blocker will make things so much better and will work when other medications don't. Yeah, see, it really does follow. So next time you see your neurologist, you can bug them and tell them to draw out the synapse and show you where your medications work. But it makes so much sense. This is that concept of rational polypharmacy. We aren't just targeting one place over and over and over again. We are thinking about it. And whenever I'm seeing kiddos, I am very careful in selecting the medications that, based on the information we have, which is limited, these are the targeted medications that are going to be best. And having that genetic testing helps guide it. Okay, so back to genetics, now that we've done our little pharmacology detour. Who are we going to test? Not everybody requires genetic testing. I'm going to say that again. Not everybody with epilepsy requires genetic testing. So who are we going to focus on? We're going to focus on those with a highly likelihood of a genetic cause for their epilepsy, which makes sense, right? Someone who has epilepsy because of a stroke probably does not need genetic testing. We know why they have epilepsy. So we're going to focus on those. If there are family members, so you have multiple people in a family with epilepsy, we're going to target those. But also remember that genetic does not mean inherited. So if no one in the family has epilepsy, you can still have a genetic epilepsy. In fact, many times genetic epilepsies are a new change in that person. So most often it happens when there isn't a family history of epilepsy. So if your doctor says, hey, I want to do genetic testing, and your response is, yeah, we don't need that, no one in the family has it. Not so. That could be a new change just to that person. So if we have drug-resistant epilepsy and we don't know why, we have early onset epilepsy. So in my world, we do a lot more genetic testing compared to the adults. Early onset epilepsy, and we don't know why. If we do the MRI and it doesn't give us the answer, or if we see that the brain didn't form correctly, but across the whole brain, then we're going to do genetic testing. If there's other features, like other organs involved, we'll think about genetic testing. And certainly if there's a progressive course. So if the person is continuing to decline, then we'll think about genetic testing. All right, we're halfway through. What questions do you all have so far before we dive into some case examples? Yes? Significant. It's usually first or second generation relatives. So cousins, yeah, first cousins. So it would be parents, grandparents, aunts, uncles, cousins. Anything farther than that, probably not. Yes. Yeah. Well, it would certainly make you more interested in genetic testing, but also make you want to also ensure there isn't an underlying cardiac abnormality if you have multiple SIDS, looking for underlying metabolic disorders. SIDS will often present right about the time that babies are sleeping through the night and no longer getting fed every 3 or 4 hours. So SIDS can be a manifestation of someone who can't fast. And so is it an absolute slam dunk? No, not necessarily, but it's one of these situations where, yeah, it makes you think, this is a family that should probably be looked at a little bit more with genetics. I would talk to your neurologist and ask about genetic testing, ask for a referral. Well, I'm not going to get into that battle, right? But it is reasonable to advocate. Yes? Sure.
What's the best verbiage to tell your doctor whether or not you take it seriously? How do you bring up that concern to your doctor?
So when we do genetic testing, we start with the person who has the disease. So that's going to be, the first part is going to be your family members because they have the disease. And so the first step is for that person to have genetic testing. And then if we identify a specific genetic cause, then we can screen family members specifically for that genetic cause. Does that make sense? Because otherwise it's just such a wide net. Start.
Something shows up.
You got it. Yep.
Shows up there.
Then you can, yeah. All right, let's dive into some case examples. Okay, so we have 2 tiny tots. Yes, they're so cute. All right, so our 2 tiny tots had no pregnancy or birth-related complications at all, both born full term. There's no family history of epilepsy or seizures. There's no developmental concerns, but they're newborns, so, can't say a whole lot there. No other health issues, but there's a question about seizures for both of them. And so this little one, at 4 weeks, she had recurrent events where her whole body would stiffen or would bend down at the waist, showing up in clusters. Initially, they thought that it was reflux because it seemed to happen more when she was feeding. They sent her for an EEG, and I know you guys are not EEGers, but I will tell you that in a 4-week-old, you should see brain activity. And this was someone who was awake and moving around, and there was almost nothing. And then we recorded a focal seizure, and we recorded an epileptic spasm. Our next little babe, also 4 weeks old, her seizures, she would stop breathing, she would turn blue, and sometimes she would start shaking on one side, and then she would move to shaking on the other side. So the seizures seemed to kind of change throughout the event. But in between, she was doing what she was supposed to do. Remember, this is a 4-week-old, so, what do we expect them to do? She would wake up, she would feed, she would sleep, she would cry, she would do her normal baby things. And her EEG was totally appropriate for age. So these are 2 4-week-olds, still the same story, totally different paths. So what do we suspect for these babies? What are we going to do? Well, these are tiny babies, right? They are just little. They don't have a family history to suggest anything. So we're automatically going to think about a gene change, but they don't fit into anything super specific. So at this age, remember, tiny baby, they're not looking like a specific syndrome, they're having a bunch of seizures. This is where we're going to cast a wide net. So we're, do not pass go, do not collect $200, go straight to whole exome or whole genome sequencing. So that's typically what we do. And why is that? Well, our tiny tot number 1 with the very abnormal EEG, she has a syndrome called ID, early infantile developmental and epileptic encephalopathy, and this is associated with some specific gene changes, but notice it's not 100%. So we don't always find the answer, but when we do, this is a situation where using a sodium channel blocker might help. For baby number 2, she actually has self-limited neonatal epilepsy, which is a genetic change. There's also a familial form. It's the same genetics. For this baby, it was just new genetics to her. Seizures respond great to medications. They all outgrow it, and they do really, really well. So casting a wide net, doing extensive genetic testing helps us identify preferred treatments, makes the syndrome diagnosis or confirms the syndrome diagnosis, and allows us to provide guidance to parents for outcomes. That's very important. So take-home points, who are we going to test? We're going to test all of our tiny babies who don't give us the answer with the MRI. And why is that? Because there are preferred treatments, and it helps us guide outcomes. What about this, again, adorable little trio? So here's our thought-provoking threesome. So now instead of 4 weeks old, we're now 6 months old. So all of them are 6 months old. All of them have normal growth and development, no prior medical history at all present with a concern for seizures. So what's going to make these babies worse or different? So this little one has had recurrent events, mostly when she wakes up. Again, she will just kind of have clusters where she does this. They make her really mad, and she cries. In the meantime, she's stopped doing a lot of the things that she was doing. Before this, she was rolling over. She, was thinking about crawling. She was sitting. She's not doing that, and she's just out of sorts. And so we saw her in clinic, and we asked, well, was there anything prenatal? And they said, no. And then they came back with, well, on that 20-week, like the anatomy ultrasound, they said there was something funny with her heart. So they repeated the echocardiogram when she was born, and she was totally fine. That's all we had. This little guy came to the emergency department having a left-sided convulsive seizure that was going on for 30 minutes. It's a long time. He was having a fever. 2 months ago, he did the same thing, except it was the other side. And Dad and Grandpa both had febrile seizures. And then our last little one was also having seizures, also having a fever, except it wasn't just one single convulsive seizure. She kept having just clusters of short seizures. Her grandmother had epilepsy and a learning disability. Her father is fine. So what are we going to do for these babies? Well, our first baby is actually presenting with a very, very classic picture. She's got something in her heart. When we looked at her skin really carefully, we saw these little pale patches. Her MRI was abnormal, and we saw what are called tubers. And so this baby has tuberous sclerosis complex. It's a very classic presentation, so we just skip and right to single gene testing and confirm the diagnosis of tuberous sclerosis. Why do we test for tuberous sclerosis complex? Again, it guides treatments. We have to monitor multiple organs throughout their life. It gives us an idea for the future. And there are preferred medications if you have epilepsy due to tuberous sclerosis complex. Vigabatrin is preferred for those spasms, but there are some medications with very limited syndromes where you can prescribe them. Cannabidiol, the brand name is Epidiolex, is one of them, and tuberous sclerosis complex is one of the 3 indications. Now, sometimes the picture changes. Let's say it wasn't just this classic picture. Things are looking a little bit muddy. The MRI doesn't give us the answer. So we're not going to move on to single gene testing then. We're going to do more expanded because it's not that clear-cut picture. So just because you present as a baby and you have spasms doesn't mean we know exactly what's happening. Then we're going to move on to an epilepsy panel, whole exome, whole genome sequencing. So our second baby had the single prolonged hemiconvulsive seizure. Anybody know what that baby has? Anybody want to guess? Huh? Go aheid and say it. Dravet, yes. So this baby is again, a classic picture, right? That is the classic picture for Dravet syndrome. And so when it comes to Dravet syndrome, 75% of the time, maybe a little bit higher, it's due to a change in the sodium channel. So you could consider just going right to doing that. That was one of our gene changes on the initial 4. So you could do that, but you also have to recognize it's not 100%. So you could also consider moving on to a more expanded genetic panel. And then, of course, Dravet syndrome. Again, there are preferred medications. There are medications we should not use for Dravet syndrome. And there are medications that have, again, that unique indication just for Dravet syndrome. And, of course, gene therapy we're continuing to do studies on it. It is not yet approved. And then our baby number 3 does not have Dravet syndrome. Again, presented with convulsive seizure in the setting of fever, but they were clusters. So baby number 3 has something called PCDH19-related epilepsy syndrome. Why does that matter? Because medications that you can't use in Dravet syndrome can be used on these kiddos. And this one selectively affects girls. You actually have to have 2 X chromosomes to have any symptoms. So, take-home points from this cute little threesome. The clinical history, the presentation, very important. So if you are ever getting annoyed at people asking you so many questions and doing weird exams on your child, like pulling out a black light, recognize it's all for a reason. It guides what we're doing. Sometimes that single gene testing is enough if it's a slam dunk case. Otherwise, we're going to do more expanded. Then we move on to our toddling trio. So we've gone from 4 weeks to 6 months, and now we've got a bunch of 18-month-olds. Again, normal growth and development, a little bit of speech delay, but really at 18 months, how much do we worry about a little touch of speech delay? Not a whole lot. They all presented with a convulsive seizure at age 18 months. They all had a concern for seizure recurrence at age 2 years. So what's going to make these guys different, and how does that affect our testing? So this little one at 18 months had her febrile seizure. At 2 years, had a generalized tonic-clonic seizure. But it was just a single one, so we waited until she was 2.5 to start medications, because then she started having myoclonic seizures. So we've gone from febrile seizures to generalized tonic to myoclonic. So that's already a bit of a concern for a genetic change. But the biggest change is that at age 3 years, things really started to spiral out of control. She was having multiple seizures, she was falling frequently, and her vision was declining. So by now she requires glasses, and when we did an EEG, we saw a very particular change, where at the slow flash frequency, we saw a genetic change, or we saw a change on that EEG. Whereas our toddler number 2, he had his febrile seizure at 18 months, and then at age 2 years, he starts having staring spells. They're worse in the morning, especially if he sleeps late, like a 2-year-old ever does. He is basically normal developmental delay. He was a late walker. His head is smaller than it should be. Especially compared to his parents. It's not super small, it's 20th percentile, except his parents are 80th percentile. So that's the other thing. Sometimes you will be part of the exam. So we went through, measured the kid's head, measured the parent's head. And I watched him just doing this the whole time he was in his stroller. Family history, nothing for epilepsy, but if mom exercised before breakfast, she would get leg cramps. We did EEG, and he was having absence seizures. So now we have a 2-year-old with absence epilepsy. And then our last one had focal seizures that have been very refractory to 5 different medications. She's got normal growth and development, and she has an abnormal MRI. And also, dad has epilepsy, but responds great to just one medication. Grandmother has epilepsy, and has never been seizure-free. So how does that history make a difference for the genetic testing that we're doing? So the first one, that particular EEG change, I'm spelling out a picture of a child who is declining. She is losing milestones. Her vision is declining. She has multiple seizure types. She's spiraling out of control. So this kiddo definitely requires genetic testing. And that EEG pattern, this pattern, is very specific for a particular genetic metabolic disorder. And if we pick up this disorder, there is treatment, but the treatment just halts the course. It doesn't reverse what has been lost. So it's going to be really important for us to not only do genetic testing on this child, but for us to do it right away. Because if we wait too long, she will not qualify for treatment. So yes, genetic testing can be incredibly important. It can be life-changing. For this little guy, he has glucose transporter deficiency. So that means that the sugar cannot get from his blood to his brain. Well, that's a big issue, right? And your brain only runs on 2 fuels, glucose and ketones. So if you have glucose transporter deficiency, you have to go on the ketogenic diet. You have to have ketones. Did I see a question back there? So again, this can totally change the trajectory. I have 2 little kiddos, 2 little girls who were both diagnosed with GLUT1 at the same time, same age. They're both adolescents now, so we're more than a decade into this. One who was actually sicker when she started, in a decade, has only eaten 1 piece of candy, has had perfect compliance other than 1 piece of candy last year. I mean, that's pretty impressive, right? The other one, right, so guess what? One has been seizure-free for over a decade, on no medication, is in a mainstream classroom. The other one isn't. So yes, you have to make that diagnosis. You have to make it early. It changes the long-term outcomes. So for these kids, again, we could start with targeted, or we could move on to more expanded testing. And then the last one has a familial genetic change. What difference does that make? Well, again, not only does recognizing the genetic change the medications you use, but in this situation where she's got an abnormal MRI, identifying the genetic change makes a difference for whether or not you're a surgical candidate. If that genetic change is at the level of an ion, you're not a surgical candidate, even if you have an abnormal MRI. So very much makes a difference. So confirming that diagnosis, again, significant difference for treatments, outcomes. And then last but not least, we can't forget about our older kids. So now we have a 13-year-old with generalized epilepsy, normal growth and development. Seizures started at age 10 or 11. She had brief myoclonic seizures, especially in the morning, became more apparent as she went through puberty. She had a generalized tonic-clonic seizure, and that's when she came into the doctor, and she was diagnosed with juvenile myoclonic epilepsy. You guys ever heard of that one? Most of the time, those kids do reasonably well. 80% of the time, they respond well to medications, essentially normal growth and development. So those kids don't actually require genetic testing. Even if there's a family history, you're unlikely to find a genetic cause in this situation. But there are some red flags, some things to look for, and this kiddo had them. So she initially did great, but then at 15, her myoclonus got a lot worse, and it came out when she was trying to do things. So when she was trying to text on her phone, you would see a lot of jerking. She couldn't write in class. She had to have someone write for her. She had trouble walking. That's something called action myoclonus. That's a big red flag. Her grades started to decline. Second, big red flag. Her walking became unsteady. Third, big red flag. And her little sister just got diagnosed with epilepsy. So now we have a family history. So with that change, now we have to do genetic testing. Now we're dealing with a progressive myoclonus epilepsy. This is the most common type, and the big red flag there was, again, and that myoclonic seizure that was getting in the way of what she wanted to do. So this is, again, very typical for a specific genetic change. You have to know about the genetic change because a microarray panel, whole exome, whole genome was not going to pick it up. This is a situation where you actually have an expansion of the genetic code. And so we had to test specifically for that and identify it. So who are we going to test here? Again, anyone with a progressive cognitive decline, motor decline, other features showing up, family history, and becoming refractory to medications. So our overall take-home points: genetic testing is not perfect, right? So just because you have negative genetic testing, if we still haven't found the answer, it means that you go back and you talk about it again a few years later. This field is expanding exponentially, so try again in a few years. We don't always find the cause for epilepsy, but 50% is actually pretty good. We're going to do the testing to help identify an underlying cause, the likelihood of other affected members of the family. It helps guide treatment. It helps determine long-term outcomes, and it helps provide answers. Who are we going to test? If there's a family history of similarly affected family members, if there's drug-resistant epilepsy of unknown cause, early onset epilepsy of unknown cause, a progressive course, MRI doesn't give us the answer, or there's other features. And how are we going to test? Sometimes it's going to be just a single gene change, sometimes it will be a microarray, sometimes it will be an epilepsy panel, and sometimes it'll move on to whole exome and genome sequencing. So again, if someone has said, yes, you've had genetic testing, follow it up and ask why. Ask what type of genetic testing you've had or your family member has had. Ask if there is additional testing that is necessary. That's it. Thank you. Yep. Mm-hmm.
Do they ask them to reform the testing, or can they just go back and reanalyze the?
It depends on the lab, but a lot of labs will just go back and reanalyze. And the nice thing is a lot of labs are intermittently doing that automatically. So, so recently I got an email from a lab on a patient who had genetic testing 5 years ago. And they said, hey, we've we've now identified this variant and reclassified it. So a lot of labs are automatically doing it. But always good to ask, though. Any other questions? Yes.
With regards to like almost the function of your practice, that
Pretty well. If we can find the genetic cause, then that's part of the analysis. So we again identify a genetic change. It's part of. So it'll say, we've had this change, and this change is associated with either gain of function or loss of function. So, but what I've found is not all. You have to read through the fine print, though. And so I have seen patients where it was pretty obvious that the physician didn't do that. One of the best examples is like SCN8A, which can have a very different look to it if it's gain of function or loss of function. And everybody automatically thinks about the gain of function, and so they see this genetic change. They automatically put the kid on a sodium channel blocker. They don't do well. It was right there in the fine print that this was a loss of function change, but the physician has to read it. So that's the next question. If you're told that you have a genetic change, ask how it affects things. The information is usually there in the results. You just have to, again, you have to read through a lot of fine print to find it. Any other questions? All right, thank you very much.